Welcome to Ward G9 at West Suffolk Hospital. We operate 27 beds dedicated entirely to specialized respiratory medicine. The patients arriving here are acutely unwell. You will be managing individuals suffering from chronic obstructive pulmonary disease exacerbations, severe pneumonia, COVID-19, and pulmonary fibrosis. To keep these patients stable, our environment is heavily reliant on advanced hardware. You will be operating NIPI machines for non-invasive mechanical ventilation, managing Airvo high-flow oxygen systems, and caring for patients with tracheostomies. This concentration of specialized equipment and high-acuity illness designates Ward G9 as a Level 2 respiratory step-up unit. Patients are admitted here because they require a density of monitoring and intervention that a general medical ward cannot safely provide. Mastery of respiratory physiology is the prerequisite for clinical safety on this ward. Every mechanical intervention we deploy is a response to a specific physiological failure. By understanding that why, you can predict how a choice will alter the chemistry inside your patient's lungs. Detecting deterioration starts at the bedside with a structured A to E respiratory assessment. This is your primary diagnostic filter. Before looking at a monitor, look at the patient. Evaluate their work of breathing. Watch for the use of accessory muscles in the neck and chest, and check for cyanosis, a bluish discoloration indicating severely low oxygen in the blood. Next, listen to the chest. Auscultation gives you immediate clues about the structural pathology. A wheeze suggests constricted airways. Crackles indicate fluid or consolidation in the alveoli. Stridor points to an upper airway obstruction. Once you identify physical distress, you need objective data. We draw an arterial blood gas, or ABG, to get a precise numerical map of the patient's internal respiratory mechanics. This chart illustrates the first distinct pathway of failure. In type 1 respiratory failure, the patient's oxygen level drops low, but their carbon dioxide remains stable and within normal limits. The lungs are failing to oxygenate the blood, but they can still ventilate. Type 2 respiratory failure presents a different signature entirely. Here, oxygen drops, but carbon dioxide spikes into the danger zone. This indicates ventilatory pump failure. The patient is physically exhausted and unable to clear waste gas from their system. We then use structural investigations like chest X-rays and CT thorax scans to visually confirm the exact physical blockages or damage driving those abnormal blood gas results. Distinguishing between type 1 and type 2 failure is the critical pivot point of your shift. That specific blood gas chemistry directly dictates every decision you make regarding oxygen delivery and mechanical ventilation. This diagram maps the strict hierarchy of oxygen delivery on Ward G9. We begin at the base with nasal cannulae for low flow requirements, moving upward to simple face masks for escalating flow rates. When a patient requires highly specific oxygen concentrations, we utilize Venturi masks. These color-coded valves allow us to deliver exactly 24, 28, or 35% fraction of inspired oxygen, ensuring controlled therapy. At the absolute top of our non-ventilator escalation pathway sits high-flow nasal oxygen, utilizing the Airvo system. This delivers heated, humidified oxygen at very high flow rates to support severe respiratory distress. However, aggressive oxygen delivery carries severe risks, particularly for our patients with chronic COPD. This schematic demonstrates the hypoxic drive. In chronic COPD, the brain relies on low oxygen levels to trigger breathing. If you flood that patient with high concentrations of oxygen, you signal their brain to slow the breathing rate. The lungs underventilate, and lethal levels of carbon dioxide rapidly build up in the bloodstream. Because of this risk, we enforce strict, distinct target oxygen saturations. Patients with normal lung function are targeted at 94 to 98. Known CO2 retainers must be maintained between 88 and 92%. On Ward G9, oxygen is a highly potent drug. You must administer precise doses. Overprescribing it can trigger fatal iatrogenic complications. When oxygen therapy alone fails to correct the blood gases, we escalate to Level 2 care using non-invasive positive pressure ventilation, or NIV. This graph charts airway pressure over time. We use CPAP, or continuous positive airway pressure, for type 1 failure or heart failure. It applies a constant, steady pressure to keep the alveoli open and drive oxygen into the blood. For type 2 failure and COPD exacerbations, steady pressure isn't enough. We switch to BiPAP, or bi-level positive airway pressure, which alternates between two distinct pressures to actively assist the patient's breathing cycle. The lower baseline is the expiratory positive airway pressure, or EPAP. This base pressure stents the airways open during exhalation, preventing them from collapsing, which improves pure oxygenation. The high peaks represent the inspiratory positive airway pressure, or IPAP. This provides the mechanical thrust. It physically forces air into the lungs when the patient inhales, creating the large tidal volumes necessary to blow off excess carbon dioxide. Managing NIV requires intensive nursing care. You must ensure a strict airtight mask seal, actively prevent pressure sores on the bridge of the nose, and continuously reassure anxious patients who are fighting the machine's rhythm. After initiating or adjusting NIV, you must draw a repeat arterial blood gas. This data proves whether your pressure settings are successfully clearing the carbon dioxide, or if the patient is continuing to deteriorate. Mastering non-invasive ventilation means you are actively manipulating pressure variables to physically force a correction in the patient's blood chemistry. Beyond the machines, Ward G9 operates on a rigorous daily rhythm. We execute continuous oxygen rounds, administer specialized medications, and maintain strict infection control protocols, especially during aerosol-generating procedures. Managing thick secretions is a constant battle. Our respiratory physiotherapists intervene daily, using manual percussion and active cycle breathing techniques to facilitate sputum clearance for severely compromised patients. We also rely heavily on speech and language therapists. They conduct meticulous assessments of swallow risks, ensuring our patients, particularly those with tracheostomies, do not aspirate food or fluids into their compromised lungs. Despite our best efforts, you must be prepared to preempt and manage high-risk medical emergencies. We drill constantly for sudden NIV failure, massive hemoptysis, and the rapid onset of tension pneumothoraces. This is the NEWS2 scoring matrix. We use it to quantify a patient's vital signs. A rising score is the objective, non-negotiable trigger for escalating care. It tells you exactly when to call for emergency medical assistance. When you trigger that escalation, you must communicate clearly. We use the SBAR framework, situation, background, assessment, recommendation, to deliver rapid, standardized handovers to the responding doctors. All the technical respiratory equipment on this ward is useless without the rapid, coordinated, and precise communication of the entire multidisciplinary team. This blueprint shows the unified pathway of care on Ward T9. Physical A to E assessments drive diagnostic APG data, which dictates precise mechanical interventions, all executed by an integrated multidisciplinary team. Excellence in this field requires moving past rote task completion. It requires a firm grasp of the physiological principles beneath every protocol and every alarm. That technical knowledge exists to serve a single purpose: delivering compassionate, individualized care to breathless, highly anxious human beings. These first principles provide the foundation for your clinical practice, enabling you to lead the team and eventually sign off junior staff as competent.